Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, Dr. Caitlin Rivers, an infectious disease epidemiologist and senior scholar at the Johns Hopkins Center for Health Security, returns to the podcast to talk with Dr. Josh Sharfstein. Their topic is how to measure the response to monkeypox. Let's listen.
Caitlin Rivers, it's so great to have you back on Public Health on Call. We want to talk about monkeypox today, and I understand that you have a new Substack newsletter where you have been writing all about it.
Yeah, thanks. Good to be back here with you. And I do like to keep my eye on what's going on with outbreaks. So thank you for that.
So we've talked about different components of monkeypox, the international dimension, the communications dimension, but you've really been focusing on the numbers.
Yeah, that's right. So I think our goal needs to continue to be containment, which means to me eliminating domestic transmission in the United States. But that's a tall order because probably today we're going to cross the 10,000 case mark, which is a lot. That's a long way to go to zero cases. And so I think to be able to get there, we need a series of metrics and targets by which we will guide our progress and notify us or identify areas of weakness in our response so that we can bolster those.
Now, back in the early days of COVID, we were learning about certain ways to measure the growth of an infectious disease. Do those apply here too?
They do, and certainly case counts are available for monkeypox, so we can look at the trends over time. But what we really want to know is whether the whole picture, the whole epidemiological picture is pointing in the right direction. So it can't just be case counts. We also need to know how well our testing apparatus is working, how well our contact tracing is working, and whether we are effectively breaking chains of transmission. And that's why I think we need a small set of simple metrics to accompany case counts to help us to understand where we're going and to ensure that we get there.
Got it. So let's start with case counts. How often should that be reported? What kind of data do you like to see to feel confident that you're getting all the information?
Right now, the CDC updates case counts every weekday, and we've been averaging somewhere around 400 new cases per day. Now, those data come from jurisdictions, state and local public health departments, and many of those jurisdictions also provide their own updates. And I think that's working well. I think daily case counts are readily available, and it's easy to see trends.
Now, do you feel confident that most people who need tests can get tests at this point?
I'm not confident in that. Our testing capacity throughout the country is about 80,000 per week, which I do believe to be sufficient, but we're only using about 10% of that capacity. Our test positivity has been hovering in the 40 to 60% range, and I think it does need to be much lower. And so that suggests to me there are problems with people recognizing that they may be at risk of monkeypox, accessing a doctor, and the doctor being able to suspect monkeypox and send off for diagnostic testing.
So in addition to the positive case counts, you'd recommend the percent that are positive of all the tests taken as another measure to track?
That's right. The number of tests run, positive and negative, and from that you can easily get test positivity.
Now, this may be a little bit different than COVID. For COVID, it's pretty easy to get a stuffy nose. You can get allergies. There are a lot of things that could make people go in. And so you expected the positivity, if there was adequate testing, often to be 5% or less, something like that. We saw during surges, it could go up to like 50% in some areas. Monkeypox is a little bit different. It's a pretty unusual rash. How do you put that together with the percent positivity indicator?
That's right. It is a little bit different interpreting test positivity for monkeypox than it was for COVID for the reasons that you mentioned. It could be that clinicians are so good at recognizing monkeypox that they don't even need to swab other lesions. And so the test positivity is very high. I suspect that's not the case here because this is a new disease for patients. It's a new disease for clinicians. and the presentation is different than what has historically been reported in the academic literature. It's not the large boils that were common in textbook photographs. Many people are reporting a single lesion or just a few lesions, and they may be flat or have an alternative presentation than what clinicians may have learned in school.
If the test positivity is very high, does it make you think that maybe we need a better test that can catch it earlier?
That's an interesting question. It's not clear whether the illness is diagnosable in the prodrome period before the rash develops. And it's also not clear if people are infectious during the prodrome period. And so those, I think, are really important areas of research. Right now, the test is taken by swabbing a lesion. And so you have to wait for the lesions to appear in order to really enter the diagnostic testing pipeline. And so I think alternative modalities like saliva, for example, should be investigated to see whether there are other ways to identify cases.
Got it. What other measures do you think should be focused on at this point in the epidemic response?
A measure that was really important during the 2014 Ebola outbreak in West Africa was the proportion of cases arising from known contacts. It's a little bit of a wonky phrasing there, but ideally, every new case would be diagnosed only in someone who was already in quarantine because they knew they had had an exposure. The benefit of this is twofold. One, it means that the person who goes on to develop infection didn't have an opportunity to pass the virus on because they knew they were at risk and they were in quarantine. Second, it means that epidemiologists have found all of the chains of transmission and are actively breaking them. Right now, we know that we really only have one data point on the proportion of cases arising from known contacts. Comes from the UK, very small at 8%, a lot of room for improvement there.
That really shows that this is an infection that's spreading well beyond the efforts to stop it at this point.
That's right. And colleagues from the UK have also reported that contact tracing has been difficult for this outbreak because many cases are unwilling or unable to elicit their contacts. And so that is a challenge. But I think even if we're not able to reach 100%, which is a high goal, if we could even get to 50% or 80%, that would mean we're really going a long way towards breaking those chains of transmission.
And then a related, perhaps, metric that you write about in your latest Substack post is time to isolation. Can you talk about that one for a second?
That's right. So we want people who suspect or are confirmed to have infection to isolate, to stay at home, to avoid close contact with others so that the infection doesn't pass on. The shorter that number is, the shorter the time from rash onset to isolation, the less opportunity there is for the virus to spread. Right now, according to CDC, it's about 6 to 7 days. And I think if it were more like 2 days, we could be more confident that we're really slowing down the virus and preventing it from reaching new people.
Got it. And it seems like that could be a little bit related to this question of cases arising from contacts, because if people are expecting to get it or they're worried about getting it, they're already in isolation, they probably would diagnose it faster and stay isolated.
That's right. All these metrics, I think, really work together and contextualize one another to give us a sense of what all is happening with the outbreak and how we are doing in our response.
So before I ask you how we're doing with monkeypox, how are we doing with measuring monkeypox? Where are we in this country in terms of setting up a system of metrics that could be something we could manage this outbreak response to?
I think there's a lot of room to grow. CDC just a week or two ago published their first technical report for the outbreak, which really goes into epidemiological detail about the data they're seeing, and that was really helpful. I think continuing to publish updates to the technical report and continuing to find new ways to contextualize what's happening with data is really important. The piece that's really missing, though, is the metrics and targets. How will we know we are making progress towards containment?
And you'd like to see not only that set at the national level, but that it would carry through. People could know in New York or in Baltimore, or New Orleans, those basic metrics and really get a snapshot of how well containment efforts are going.
That's right. Public health officials at the federal level could help to propose and set those metrics and track them at the national level. But it's really state and local health officials who have the authority to collect the data and the responsibility to drive the local response. And so it does need to be an integrated response across all the levels of our public health system.
If we don't have that, is it going to be hard to know how well we're doing?
Well, my concern is that the outbreak will come under some kind of control. It will start to slow down, as we're seeing in Europe, and then we'll lose focus on reaching zero. I think getting to a low level of transmission is not good enough. We need to be aiming for zero, and that is a very tall order. And in order to achieve it, we really need to have a systematized approach to getting to zero.
I'm going to ask one other question, which is a little bit broader, which is the need for a strong state and local public health system to actually do the work in all these different places, track down all the cases, report all the data. We've heard a lot in this podcast and elsewhere about the weaknesses of the public health system, the underfunding of the public health system. And even if you do get to zero, more cases could come in the future. So, is this a pretty good example of the underlying point that we're only as strong as our fundamental public health infrastructure?
Absolutely. And it's not just monkeypox. It's also COVID, which was enormously taxing for our public health system. There are now concerns about a resurgence of polio, which has been eliminated in the United States for decades. And so I think that we're really seeing the way that our public health system can become brittle and threats that we're not accustomed to thinking to because they have so long been under control begin to break through.
Well, Dr. Rivers, thank you again for joining us, and thanks for sharing all your wisdom online and with us.
Thank you. Good to be with you.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.